I've gone through renal cell carcinoma, yes. Renal calculi. Doing a CT KUB, not an X-ray KUB. It's non-contrasted. It's very important. It's done that. Acute kidney injury, I've done that. Different types. Sepsis, I've done that. Diabetic nephropathy, done that. So renal, let's say, passes has been done. One pass not gonna help me. Endocrine, psych, room, genitourinary. Haven't gone through any of those. So 1, 2. Gastro, have I done gastro? I've done peptic ulcer. No, I haven't done all of gastro. Should do that. Diagnostics. Yep, I haven't done this at all. Nope. We're gonna smash out gastro today. So that means 38 days, and I've got 1, 2, 3, 4, 5, 6, 7 topics done. I've only done 1, 2, 3, 4, 5, not even halfway through. Let's go. I can do this. It's done. What are my differentials and provisionals for a peptic ulcer? I'm concerned about pancreas. We'll start with life threats. I'm concerned about an MI. What causes of chest/abdominal pain could include vascular causes such as a pulmonary embolus, dissection AAA, respiratory causes such as a pneumothorax, and I'd like to exclude other gastrointestinal pathologies. Pancreatitis can present with epigastric pain, acute cholecystitis, biliary colic, and then also other more benign causes such as gastroenteritis, right? Right, so this patient basis. There's vascular dissection. Mesenteric ischemia is a life threat you need to talk about with epigastric pain. Mesenteric ischemia, pancreatitis, tumors, we did mention GORD, pleuritic chest pain, pericarditis, they include inferior MI. Okay. So what are my provisional and differential diagnoses? My provisional diagnosis would be that of a peptic ulcer with peritonitis due to the presence of rebound tenderness and guarding. I would like to then exclude other differentials. We'll begin with life threats, inferior MI, pneumothorax, pulmonary embolus, other vascular causes such as dissection, AAA, and then respiratory causes, we mentioned pneumothorax, gastrointestinal causes, life threats including mesenteric ischemia and pancreatitis. If it was a male, I'm always concerned about ruptured ectopic, ovarian torsion, pelvic inflammatory disease, and I'd like to exclude malignancy, patient's age. Other benign causes could include gastritis, GORD, changes in pain experienced, and that's because you ruptured the parietal peritoneum on top of the visceral, reflections of the peritoneum. Go through all of that. Start with this, appendicitis. A 16-year-old girl presents with anorexia, abdominal pain that originates in the epigastrium and moves to the right iliac fossa. She has a temperature of 38 degrees. Blood pressure is normotensive depending on the patient's weight. And heart rate is not tachycardic, so she's hemodynamically stable. What is my provisional and differential diagnoses? Given the presence of anorexia and abdominal pain that characteristically begins the epigastrium radiating to right iliac fossa, I'm concerned about acute appendicitis. I would like to exclude other differentials of epigastric abdominal pain. We can begin with life threats, so this can include vascular causes such as abdominal aortic aneurysm, aortic dissection. I'd like to exclude pulmonary embolus, inferior MI, and then gastrointestinal causes that can be life threats could include mesenteric ischemia, pancreatitis, and other benign pathologies at the epigastrium associated with anorexia could include GORD, peptic ulcer disease, gastroenteritis, given that she is febrile but hemodynamically stable. What are the signs and symptoms of appendicitis? Appendicitis is caused by inflammation to the appendix, most commonly secondary to a fecalith that impacts matter into the appendix. And the original inflammation causes sensitization of visceral fibers that are generalized, travel with the sympathetics, and so they can observe a generalized, non-specific epigastric pain. And as inflammation proceeds to the parietal peritoneum, and this could occur after rupture of the appendix, there is peritonitis, and parietal peritoneum gives a sharp localized pain at the right iliac fossa. This is most prominent at McBurney's point, which is located 1/3 from the anterior superior iliac spine to the umbilicus. The patient will also be febrile, given the inflammatory process and release of cytokines. Other symptoms could include nausea, vomiting, anorexia, and other signs could include Rovsing sign, in which palpation of the left iliac fossa and release results in a rebound tenderness at the right iliac fossa, and psoas sign, in which flexion of the leg can elicit pain. What investigations would you perform? I'd like to begin with bedside investigations. I'd like to do an ECG at the bedside just to rule out any cardiac causes, pericarditis, MI, for example, unlikely given the patient's age. I would like to then proceed to laboratory investigations, including a full blood count with differentials, to look for any evidence of leukocytosis, signs of infection, and then could consider a CRP, given the patient is febrile. I would then like to get EUCs, just to rule out pyelonephritis and other renal causes. And we also notice in GI bleeds that there may be an increased urea to creatinine ratio. I'm also consider doing LFTs to rule out any liver or gallbladder pathology such as cholecystitis that I could be concerned about. And I could refer to the Wells criteria, and this clearly the patient seems very low risk, and then proceed to P rule out criteria, which I also believe the patient would be low risk for, and thus would not need a D-dimer either. I could also, given that I'm concerned about appendicitis, I would like to also do coags. The patient may be going for surgery and a grip and hold, and potentially consider cross-matching, but I'd refer to seniority for this. And then imaging for the appendix, I could perform an ultrasound of the appendix to look for enlargement. This is usually definitive. However, if this is inconclusive, I could then proceed to a CT of the abdomen. What is the pathogenesis of appendicitis? Appendicitis is inflammation of the appendix, which is a vestigial structure attached to the cecum. It results from some form of impaction. It could be, for example, a fecalith, and this can cause increase in the intraluminal pressure, buildup of microbes that then cause the inflammation that proceeds across the luminal wall and can lead to rupture. And rupture can disseminate the bacterium and the causative agent in the infection to the general peritoneum, and this can result in a very localized pain in the right iliac fossa, and this can lead to sepsis and death, so it's a major concern that we must remove operatively. What are the risk factors for developing appendicitis? Patients with a young age. So I'd like to first separate risk factors into modifiable and non-modifiable risk factors. Non-modifiable risk factors could include the patient's age, any appendiceal anatomical abnormality, if the appendix is larger than normal, can predispose to it, and then specific positions, which I'm not sure of. And then modifiable risk factors include obesity, what are the complications of appendicitis if no immediate treatment is given? Well, the complications of appendicitis include appendiceal necrosis, and that can result in spread of infection. We are also concerned of sepsis and septic shock, which may result if there is perforation of the appendix and dissemination of the bacterium into the peritoneum. I'm also concerned of this can lead to septic shock, as mentioned. Could be recurrent appendicitis following first attack due to development of scar tissue, granulation tissue. How would you manage this? We would surgically resect the appendix. And what are the surface and internal landmarks of the appendix? The appendix is located at the right iliac fossa, distal to the cecum, and is at the border of the small and large intestines. Man, I butchered that. Let me quickly answer that. The surface landmark is that, the internal landmark? I have no clue, I'm not going to butcher that. What is the vascular supply of the appendix? It's the ileal branch of the iliac. The appendix is a midgut structure, so it does supply from the superior mesenteric artery, and the ileocolic artery is a branch of the superior mesenteric artery. Let me just see if Ollie hops on. Okay. What investigations would you perform? What are the vascular landmarks? As we mentioned, superior mesenteric artery, branch of the superior mesenteric artery is your ileocolic artery. What are the anatomical landmarks separating the midgut from the foregut and the hindgut? The second half of the duodenum separates the foregut from the midgut. The midgut and the hindgut is separated from 2/3 of the transverse colon. Vascular supply of the foregut is the celiac trunk, superior mesenteric artery for the midgut, and hindgut is the inferior mesenteric artery. What is the neuroanatomical basis of the shifting location of the pain in appendicitis? The shifting nature of the pain is due to innervation of different nerve fibers. Originally, inflammation of the appendix results in sensitization of visceral fibers, and these are derived from your lateral plate mesoderm, and they travel with the sympathetics. They're poorly localized, and as a result, they can be confused with. Let me restart. The pain in appendicitis, the shifting nature of pain in appendicitis is due to what's going on? Okay, I have no clue. Let's actually answer this. What is the neuroanatomical basis of the shifting location of the pain in appendicitis? The shifting nature of pain in appendicitis is due to the sensitization of different nerve fibers. Initially, inflammation of the appendix results in sensitization of visceral nerve fibers. These nerve fibers travel with the sympathetics and will sign up for the dorsal root ganglion alongside a sensory nerve. And in the case of appendicitis, the visceral nerve fibers will synapse at the same location as the T10 dermatomal nerve fibers. As a result, the body can confuse the pain at the appendix with that at the T10 dermatome, and this results in a umbilical pain. However, as we start progressing in inflammation across the luminal wall to the parietal peritoneum in the case of an appendiceal rupture, we will then sensitize the parietal peritoneal nerve fibers, and these nerve fibers are very localized, and that will result in that pain at the right iliac fossa. What are the possible positions of the appendix? Oh my god. There's like retrocecal. There's I forgot. What nerves come from L1? Man, I don't know. Complete anatomy. Help. Let's go back. Don't want kidney. Here you go back. Models are cool. Ah, that's cool. Yep. Oh my lord, I'm shocked. Okay, that makes sense. And I can go up and down. So that's it. Alright, let's have a look. What are we dealing with here? Can we remove this? Hide. What are these nerve fibers here doing? These nerve fibers, get rid of them. External iliac vein and arteries. What are these vessels? They are superior and inferior epigastrics. Right, the superior epigastrics. Let's hide. What about this one? Yeah, I can remove these epigastric veins too. Epigastric veins. What is this structure here? No, this one here. Median umbilical ligament. And what's that? Umbilical ligaments? The lateral umbilical ligament? It's also medial umbilical ligament. Just hide it all. And go here, hide it. What is that? It's a mesentery, hide it. Aorta. Iliac veins. Man, I just want to see the appendix. Where is it? Where is the appendix? I don't have. There it is. That's the appendix. And you can see, oh my god, it's sitting like squashed against us at the terminal. Oh, right, that makes sense. And from there, we are going to have our large bowel. And if I have to come up, oh, and if I zoom, right there, your small intestine hits, and that forms the cecum, which is this pouch. And then you have your appendix right there in the human body. That's the appendix. How cool. Contiguous, contains the same layers as the rest of the large intestine with unique variations. Lumen is soft, the mucosa has lymphoid tissue. This crypts. Key features. It's projects from the lower portion of the cecum. Yep. Inferior to the ileocolic junction. Yep. Right. And McBurney's point. Skin 2/3 of the way down the line between the umbilicus. So it's always most lateral. It's not close to the umbilicus. McBurney's point is 2/3 of the way from the umbilicus to the between the umbilicus and the iliac spine. Vestigial organ. As to clinical correlates. Acute appendicitis. What's a vascular supply? Let's see. Click that artery. We're going to get our answer. It's your appendicular artery, which is a branch of the origin. It's from the ileal branch of the ileocolic artery. So you have your ileocolic artery, you have your ileal branches, and these ileal branches will release the appendicular arteries. From the ileocolic artery, ileal branches, and that's your appendicular. So if I zoom out, that's what we're looking at. And so that's your appendicular artery, and that's coming off the ileocolic artery. And what is that? That's the ileal branch of the ileocolic artery. And where is the ileocolic artery coming from? See it all the way there. Oh my god, so many arteries. Okay, what about that? What is that? Superior mesenteric. Yeah, so that's your superior mesenteric. It's giving off a ileocolic artery, and that gives off ileal branches, and off the ileal branches is an appendicular artery that's going and supplying the appendix. And what's the venous drainage of the appendix? How will I forget that now that I've seen it? It's beautiful. It's beautiful. So right there, and you had your appendicular artery, which comes off your ileal branch, your ileocolic artery, which comes off your superior mesenteric artery, and your appendicular vein sits right here. Appendicular vein. Where does that come from? It merges with the ileocolic vein. Appendicular vein that comes off your ileocolic vein. And what does the ileocolic vein come off? Superior mesenteric vein, I'm guessing. Yeah, it's literally the exact same. And what does a superior mesenteric vein drain into? This is so cool. Let's get rid of that pancreas. Hide. What is that? Hide. What is that? It's a superior mesenteric vein. Where is it going? Alright, what is that then? It drains into your hepatic portal vein. It forms hepatic. So that'd be your splenic vein, your superior mesenteric vein. So that's going to be your splenic vein. Yes! So your splenic vein and superior mesenteric vein form the hepatic portal vein. And the hepatic portal vein is then going to, let me just keep track of this. This is beautiful. Oh my god. Okay, let's go up, 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 up. Remove you. Dissect, dissect, dissect. 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 Remove. Remove. It's your stomach. That's your in the liver right now, that's where we are. Highlight that vein. That's, oh my, beautiful. It's going through the liver and that's insane depth. Okay, what was my original differentials? Guy said gastroenteritis, mesenteric adenitis, seen in young kids, sure. Given her age, interception, volvulus. Volvulus happens in the first 2 months. Interception can happen in the first couple of years. Yeah, I remember volvulus age group. Hernia, hydrocele, lung lesions, malrotation volvulus. Appendicitis, 5% get complications. Infection, abscess, I didn't mention. Bowel obstruction. You get a paralytic ileus, which I completely forgot to mention. Is it 5? No, it's 55% of them get complications and get a infection or abscess, a bowel obstruction. It can be small bowel, paralytic, ileus, constipation. 1 to 5%, 2 to 9% if there's perf. Anorexia, dietary intake. There's weight loss, post-operative stump, there's sepsis, appendicitis, inflammation of the residual, there's post-operative sepsis, there's stump appendicitis, inflammation of the residual. Okay, that's very interesting. Kidney embryology, appendicitis. More than half of them can get complications such as infection, abscess. They can get a bowel obstruction. It can be mechanical, like a small bowel obstruction, which is very unlikely, but also paralytic ileus, adhesions. They can get abscess. Is that it? No, the volvulus. It's alright. Oh, I forgot she's a girl. We need to exclude pregnancy. Even if they're 16 years old, you have to exclude a pregnancy. Oh my god. I forgot that. Okay, 16-year-old girl, you need to always consider pregnancy. Gastroenteritis, dissection volvulus, mesenteric adenitis, Meckel's diverticulum. The young person. Oh, Meckel's diverticulum can happen in older people as well, right? Let's go to BMJ and see when volvulus comes up. don't know when valvulus happens. So valvulus happens in the first couple of months. Intussusception you can see in older children. So malrotation. We'll go summary, quick. Got time. Come on, into definition. When does it happen? Infant less than 1 year. Right, most commonly. And intussusception. Bowel telescoping on itself. Investigations. So much medicine. For 12 months. That would be valvulus. So valvulus typically and intussusception birth. So 1 year most commonly. However, you can get valvulus when you're a bit older, so I can say, I guess, right. Mesenteric adenitis. Mesenteric gastro, Crohn's. Key, I need your help. Easy case, but not the brightest cookie, huh? 7 minutes till the first study session. Let's at least finish this case. Right, GOT. Mesenteric adenitis, Meckel's, bowel obstruction. Yeah, we didn't mention valvulus intussusception. Stupid. It's a 16-year-old girl, right? It's gastro, mesenteric adenitis, Crohn's disease. She's a teenager. We had a shoot on teenagers with Crohn's UC, so you got to remember that. Bowel obstructions, urologic concern about GIT. So break it into GIT and urological. So UTI, renal colic, pyelonephritis, and gynecological ectopic cyst. Middle smirts, which is ovarian pain, menstrual pain. What are the signs and symptoms? You get anorexia, fever, you get diarrhea. You can commonly get diarrhea and appendicitis, and abdominal pain that starts centrally, then migrates to the right iliac fossa, and pain that's caused by coughing and moving. So typically when you have gastro, coughing is not going to make gastro that much worse. But appendicitis, there is a peritonitic picture. So obviously anything that, right, peritonism suggests perforation. There's maximal pain at the McBurney's point from ASIS, palpation of the left iliac fossa, increases pain in the right iliac fossa, and psoas and obturator signs. What is psoas sign? It's when you lift the leg up and you get pain, right? Is a medical sign. The psoas hip flexures, and the inflamed appendix is retrocecal in origin. That's typically what the appendix structure is, right? It's sitting wedged behind the cecum, so it is retrocecal. And that's the mesoappendix, the mesentery of the appendix. Okay. Coming back here. How do you do psoas test? So you get them extending the leg back and right, psoas and obturator, pain on passive extension of the right leg. The patient lies on the left side and you extend the right leg, applying counter resistance to the right hip. Extends the patient's right thigh while applying counter resistance on the right hip. Right, so like this. Right, so that is psoas sign. So what's the other side? So we get, let's see if we've got it here. Dull diffuse is guarding, rigidity, rebound tenderness, diminished bowel sounds, anorexia, fever, nausea, vomiting, tachycardia. It's atypical as it can present with generalized abdominal pain. You do McBurney's 1/3 of the distance. So localized peritonism, need for surgery, Rolfing sign. The left lower quadrant elicits pain, the right lower quadrant. Just stretching and compression of the parietal peritoneum. So when you do that, you've stretched, right? It's like pulling. Right, that makes sense. You stretch and pull the peritoneum, and that can irritate to the right side. Into the appendix. Soleus sign, left side extends the right thigh. The retrocecal appendix, then obturator sign, internal rotation of the flexed thigh. Internal rotation of the flexed right thigh causes to compress the pelvic appendix and worsens the pain. Right, that's the obturator sign. So you flex the thigh and then you internally rotate it, and if that causes the obturator muscle to compress the appendix and worsen pain. What's coming to? And that's obturator sign. Soleus, obturators, Rolfing's, McBurney's. So the signs are Rolfing's, Soleus, obturator, McBurney's. So McBurney's point is what we're talking about, and then Rolfing's sign, then Soleus' sign, and then obturator sign. You want to check for all these things. So again, McBurney's point is pain 1/3 of the way from the right iliac, the iliac spine, and McBurney's point, anterior superior iliac spine. So McBurney's point is pain from the anterior superior iliac spine to the umbilicus, and it's 1/3 of the way from the ASIS to the umbilicus. Rolfing's sign is when you palpate the left iliac fossa and you get pain at the right iliac fossa. And then what are the other signs? And then Soleus' sign is when you turn the patient to the left, you apply resistance in the right hip, but you also extend the right leg, and pain indicates that the appendix is retrocecal and it's irritating the psoas muscle. And then the obturator sign is when you flex the hip and then you internally rotate, and that can compress the obturator internus muscle to compress whatever is obturator internus. Right. Makes sense. Good image. Obturator internus goes from the right, it's obturator internus. Oh, we're in 5-minute break. Right. to it. Alright. Pain source, arbitrator sign. What investigations would I perform? Did I miss any? Ah, she's female, so urinalysis and beta HCG. Beta HCG. Any woman that comes in with abdominal pathology that's of reproductive age, you must do a beta HCG. That's so crucial. Beta HCG. Right. Women of reproductive age do beta HCG test. There's no diagnostic investigation, it's a clinical diagnosis. Break that down first. And labs, we said we do FBC, UCCRP. Forgot amylase and lipase? Come on, it's abdominal path. Do random glucose, rule out ketoacidosis. We do an ABG, look for any evidence of any acidosis. And exclude torsion. What investigation is key doing? I didn't break down signs and symptoms, fever, tachycardia, abdominal tenderness, patient fossa. How may the clinical presentation of appendicitis vary? Well, the appendix position of its base is constant in relation to the cecum. The appendix itself may lie in a variety of positions. It may be retrocecal, right, 74% of the time, and it can be pelvic the other 21% of the time. So retrocecal is sitting right behind the cecum. Then you can have pelvic the other half of the time, and then if it's retrocecal, you can get flank back pain, and you get a dull abdominal ache. You may not have right lower quadrant tenderness as the appendix does not come into contact with the anterior parietal peritoneum. And then you get a positive psoas sign. And there may not be anterior abdominal pain as the appendix does not come in contact with the anterior parietal peritoneum. Pelvic, meaning it crosses a pelvic brim, and that causes suprapubic pain, bladder or rectum irritation, so you can get diarrhea, tenesmus, urinary frequency. Can lie in a pelvic organization, a post-ileal. There's a pre-ileal, so if that's the ilium going into the cecum, it can be a pre-ileal, post-ileal, pelvic, retrocecal, paracecal, subcecal, retro-para-subcecal. Yeah, okay, that's pretty much everything. Come on. So the different clinical presentation of the appendix. The appendix, majority of the time, is it retrocecal then, did we say? Let's see. Beta HCG, amylase, lipase, you do pelvic ultrasound, and if there is perforation, there'll be pneumoperitoneum, peritoneum, valvulus, fluid torsion. Yeah, and you do abdominal ultrasound, especially in women of childbearing age. Butchered this case, man, you'd fail. Pathophys can be obstruction of the appendix due to a fecalith. It can be just a lymphoid hyperplasia, and that can be seen in children. There can be some form of calculi. It can be infections, malignancy. So what can block up that tube of the appendix? It can be a fecalith, it can be lymphoid hyperplasia, following infection. It can be malignancy, it can be stones. This increases Prevents outflow of mucosal secretions. It increases intraluminal pressure. There's an overgrowth of bacterium, and that causes infection, swelling of the appendix, mucosal distension, and that causes the visceral pain. Then the pressure of the lumen is, if once the pressure of the lumen exceeds the venous pressure, there is occlusion of the venules, and that begins a process of ischemia, and then it can perforate, and that can lead to a peritonitis and sepsis. It can lead to a phlegmon, in which the greater omentum can adhere and encase the appendix and form an abscess. And you can get post-stump appendicitis, where the remaining appendix can get inflamed. You can get abscess. You can get, the main ones. Peaks in the early teens and late 40s. And it's bimodal. Early teens, late 40s. Modifiable includes smoking, low fiber diet. And the lifetime risk of appendicitis is 7%. Smoking, low fiber diet, and the lifetime risk is about 7%. What are the complications of appendicitis if no immediate treatment is given? It can perforate. Peritonitis. It can form an appendicular mass, an abscess, and cause paralytic ileus, and that can result in third spacing. There can be fluid in the bowel, and not third spacing, which says hypovolemic shock. It could be drainage of the infection to the liver, causing a liver abscess, and chronic, there can be adhesions causing bowel obstruction. Oh my lord, so much with one case. How would you manage this? An emergency laparoscopic appendectomy before there is a perforation. Yep, and then perforation occurs, you must remove the appendix via an open surgery. Wow, that's not good. Sulcus and obturator site. CT is appropriate in adults with over 65, unclear. CT is the best investigation in any appendix. It can be fat stranding. Stranding is what you see on CT. Ultrasound can be women of childbearing age. MRI, then laparoscopy is a useful surgical diagnostic maneuver. Any pathology without a major incision. Football count ECs, LFTs, amylase and lipase, my man. It's not there. The Alvarado score enables risk stratification patients with abdominal pain, linking appendicitis to probably appendicitis to recommendations regarding discharge, observation, and surgical intervention. If there's migratory pain, if it's anorexia, Alvarado, Mantrol's, migration, anorexia, nausea, tenderness, rebound, elevated temperature, leukocytosis, shift of the white cell count to the left. What does that mean? It'd be neutrophils, right? Yeah, it's an Alvarado score to stratify whether we should discharge the patient, whether we should observe and admit or surgically intervene. Can't be used to rule in appendicitis. What's a good rule out? What are the surface landmarks? So it's under McBurney's point. Internally, it's a blind diverticulum. What is the definition of a diverticulum? Small pouches that form in the lining of your digestive system. Taenia coli are 3 separate longitudinal ribbons. Smooth muscle on the outside of the ascending, transverse, and descending sigmoid colons. They can come together like that. That's your Taenia coli, and there are your haustra. Ascending colon, ascending colon, haustra. Acute longitudinal smooth muscle coat. While the base of the appendix is fixed, the tip can be variably located. That's McBurney's point at the outer 1/3 right there. SAS, symphysis, outer 1/3. There is an opening of the appendix, and that can just drop right there. There's an ileal orifice. How do you manage this? Laparoscopic surgery. They kneel by mouth. You get IV fluids and analgesia, and you can run it at 150/20 for the first 10, 20, and then the remaining weight. Or you can just use a rule of thumb and do 125 ml per hour and modify it as per needed. Antibiotics, you can give them AMP, Gent, and Metro. Seize gentamicin after 72 hours. Initiate piperacillin. Oh my god. ETG, help us out. What does ETG actually say? How may a surgeon locate it? They converge at the root of the appendix. You can follow the Taenia coli to the point of convergence. Or you can apply gentle traction to the anterior Taenia coli. Taenia coli are 3 separate longitudinal ribbons, and they're visible and they can see in just below the serosa and the fibrosa. It's a mesocolic free and a mental Taenia coli. It's haustra. Mesocolic free and a mental Taenia coli. There's an mental Taenia coli. So many damn Taenia coli. Look, I don't need to know that. There are 3 Taenia coli. I'm not going to remember the 3. It's not important. Gentle traction to the anterior of free Taenia coli. What is the pathogenesis? And there is some kind of obstruction to appendicular outflow, fecal lymphoid hyperplasia, malignancy, and there's continued mucin secretion. The lumen fills with mucus, intraluminal pressure that can stretch the appendiceal wall and collapse low pressure venules and capillaries that can engorge these vessels, lead to ischemia and appendicitis. That's because you decrease your venous outflow, and as a result there is congestion, stasis, and there'll be appendicitis. And there is bacterial overgrowth. So it can be E. coli, Peptostreptococcus, Bacteroides fragilis. Makes sense, your Bacteroides are in your GIT. Peptostreptococcus, Bacteroides, Peptostreptococcus, Bacteroides, Pseudomonas. E. coli, Peptostreptococcus, Bacteroides, E. coli, Peptostreptococcus, Bacteroides, Pseudomonas. enters the wall. There is a neutrophilic response, there is a fibropurulent reaction, and the inflammation spreads to the serosal surface, contact with the parietal peritoneum, you get a localized irritation. And then eventually you can get inflammation of the appendicular artery, thrombosis, necrosis, and the appendix can risk rupturing. There can be superimposed bacterial infection that leads to gangrene and further increases rupture. It's contained by the greater omentum. It can form an abscess or it can cause generalized peritonitis. Bimodal, what are the complications? Is acute, subacute, and chronic. Acute is gangrene, perforation, abscess, generalized peritonitis. I said phlegmon, paralytic ileus. Chronic can be adhesions, and there can be septic seeding of pathogen along the mesenteric vessels. Because, okay, what is the management? IV antibiotics. Continued antibiotics only indicated for perforation, appendix mass or appendix abscess. I'm studying. Just keep asking questions. IV antibiotics, cefuroxime, metronidazole. It says amp and gent, but here it says kef and metro. Come on. It's amp and gent and metro, and it says kef and metro. What does ETG say? You give a gent plus metro plus amp. So it is amp and gent and metro. Amp and gent and metro. And if gent is contraindicated, then kef and metro. That's easy. So amp and gent and then metro as well. I'll just copy paste that. Thank you, ETG. Lifesaver. What is the emergency treatment? Supportive therapy and then antibiotics, amp and gent and metro. It can be E. coli, Peptostreptococcus, Bacteroides fragilis. Posteromedial, posterolateral, and anterior, and they converge. The implied gentle traction of the anterior. Superior mesenteric artery goes to an ileocolic artery. There is a posterior branch of the ileocolic artery. The ileocolic runs across the free margin of the mesoappendix and is drained by the appendicular vein, ileocolic vein, superior mesenteric, and that drains into the portal. I'm not going to forget that because I used a diagram. vascular supply of the appendix. Content. I need models. I need to see the whole appendicular system again. Abdominal viscera. Filter. No, I just need the atlas. And I need the appendix, but it's a gallbladder, the appendix, superior mesenteric artery. Right, there we go. There's our SMA giving branches. That's beautiful. So what is this? Your ileal branch. There'll also be your, oh no, that's all the branches. That's celiac trunk up there. Yeah. Just not clicking that. Okay. There's a middle colic artery. There is a right colic artery. And that's your superior mesenteric. Not the superior mesenteric. There should be a superior. There should be inferior pancreatico-duodenal artery. So there's your pancreatico-duodenal artery coming off right there. Who's that? There's your right colic artery, your middle colic artery, right, and middle colic artery. There's your ileal branches, iliocolic artery. Jejunal ileal, your right colic, your middle colic, inferior pancreatic, superior inferior pancreatico. Superior pancreatico-duodenal artery is going to be inferior pancreatico-duodenal artery, your jejunal ileal, and then your iliocolic artery, and there is a posterior branch that'll give off the appendicular artery. Okay, and appendicular vein, portal vein, foregut, esophagus, 2/3 of the duodenum at the greater duodenal papilla, distal 1/3 of the duodenum to proximal 2/3 of transverse colon, 1/3 of transverse colon to the upper part of the anal canal, and the middle colic from SMA, anastomosis with the left colic from the IMA. That makes sense. Yeah, so then is your left colic and then your sigmoid. Your left colic and your sigmoid. There's your left colic, and then there's your sigmoid, and then your superior rectal. Where does inferior rectal come from? Pudendal. Internal iliac, pudendal, and your inferior rectal. Oh, sheesh, that's so much. What is a neuroanatomical basis? Why is visceral pain? Most of the cutaneous regions. So many questions about referred pain, I might as well quickly get this over and done with. Splenic pain, left shoulder. Gallbladder can be to the foot to the back. Spleen is left shoulder. The heart can radiate there, down to the arm. Thymic pain, lung and diaphragm can feel to shoulder pain. Small intestines can be umbilical, ovarian, appendix. Kidney pain, groin to line. Bladder suprapubic. Kidneys can be felt rarely there. Alright. Neuroanatomical basis of shifting pain, visceral, peritoneal pain, midgut, hindgut, visceral afferents to the celiac plexus, greater splanchnic nerve, lesser splanchnic nerve, and hindgut should be least splanchnic nerve. T12, L1 dermatome, the umbilicus, peritoneal pain, T12, L1, it's around T10, transumbilical pain, T7 to T9, T10, T11, T12. Okay, the shifting nature of pain can be explained through the convergent projection theory, in which visceral efferent fibers will travel alongside sympathetic nerves and synapse at the dorsal root ganglion alongside somatic fibers that will supply a cutaneous region of the body. The cutaneous region of the body has a higher density of nociceptors, and as a result, as the pain travels up via the spinothalamic tract to the somatosensory cortex, the somatosensory cortex can incorrectly project the pain to the somatic dermatomal region rather than the visceral region, and as a result we can see pain at a dermatome when in actuality it is deep in the organ. Okay, what are the possible positions? There is retrocecal, paracecal, pre and post ileal, and pelvic. Subileal. Iliohypogastric, T12, L1 up to L3, L4, L5. Ilio-femoral nerve, lateral cutaneous nerve of the thigh. There is a genitofemoral nerve. There's the ilioinguinal nerve, iliohypogastric, ilioinguinal, genitofemoral, femoral nerve. Genitofemoral, inguinal. So iliohypogastric is your transabdominis, is gastric, internal oblique, transverse abdominis, scrotum, genital region, ilioinguinal, iliogastric, isio-abdominal muscles, ilioinguinal, isio-inguinal region, genitofemoral, cremasteric muscle, and scrotum. I'm not going to remember all of that, but it is what it is. The peptic ulcer in the duodenum. Now we're into peptic ulcer in the stomach. Let's go. I think what I'll do first though is answer all the pancreatitis, the appendicitis questions. That was why is everything so much info? One case a day would have been good. Okay, start a timer and get going. Okay, 16-year-old girl presents with anorexia, abdominal pain that originates in the epigastrium and radiates to the right iliac fossa. She's got a temperature of 38 degrees, so she's febrile, hemodynamically stable. What are my provisional and differential diagnoses? My provisional diagnosis in the setting of a febrile female with anorexia and migratory abdominal pain is that of an acute appendicitis. I would like to exclude differentials, including life-threatening causes of abdominal pain, and these can be potentially a lower myocardial infarct, also concerned about vascular pathologies, AAA aortic dissection. I'd also like to rule out pulmonary embolus, pneumothorax, and then I'd like to narrow down into abdominal pathology. I'm concerned about abdominal pain, mesenteric ischemia, however that's more likely in an older age group. Other differentials could include pancreatitis, and I would also like to exclude abdominal pathology, including gastroenteritis, mesenteric adenitis given the patient's age, bowel obstruction, and then genitourinary such as pyelonephritis, renal colic. And since this is a female of childbearing age, I'm concerned about ectopic that I'd like to also rule out. And other reproductive causes such gynecological causes could include pelvic inflammatory disease, ovarian torsion. What are signs and symptoms of appendicitis? The signs of appendicitis could include, the symptoms of appendicitis could include nausea and vomiting. They also may be GIT symptoms depending on the appendiceal position, and this could include diarrhea, sensation of tenesmus, for example. Most prominently, patients would be febrile due to the inflammatory process occurring at the appendix, and they may also complain of abdominal pain. That's most prominent of a McBurney's point. So moving on to the signs, the pain at McBurney's point is most prominent 1/3 of the distance from the anterior suprailiac spine to the umbilicus, And other signs that may be positive in patients with appendicitis could include the psoas sign, in which a patient turns to the left. There is extension of the right hip with traction, and we can observe increasing pain, which could indicate that the appendix is in a retrocecal position, irritating the psoas major. We could also do the obturator sign, where we flex the hip and internally rotate the thigh, and that could compress the appendix by the obturator internus muscle, thereby worsening pain. And that's positive in appendicitis. And we could also do Rovsing sign, where palpation at the left iliac fossa can push the peritoneum and the parietal peritoneum against the appendix, thereby causing irritation and exacerbating pain. What investigations would I perform? Well, appendicitis itself is a clinical diagnosis. I would first like to do a bedside investigations. This could include ECG that's done for any patient, given it could be chest pain from the history. I would like to also do urinalysis at the bedside, as this may be some renal problems, and a pregnancy test, so a beta HCG, just to confirm if the patient is pregnant or not. Then laboratory investigations could include a full blood count, and I could do an EOC, looking for any evidence of GI bleed, such as a raised urea to creatinine ratio, any evidence of renal impairment, acute kidney injury. I might like to also do a blood glucose to rule out diabetic ketoacidosis, given that this is abdominal pain in a young girl. And I could then do LFTs to look for any evidence of a cholestatic or a hepatic pathology. And given that I'm concerned about appendicitis, likely a coag study, group and hold, as the patient will likely be going for surgery. Imaging could include ultrasound to rule out appendicitis, especially in a woman of childbearing age. If in older populations, we may even consider CT. What is the pathogenesis of appendicitis? Appendicitis begins with some form of impaction at the appendix, and this could be in the form of a fecalith, it could be in the form of malignancy, potentially calculi, and in younger children, we also observe lymphoid hyperplasia could cause obstruction of the appendicular opening. And following that, we observe an increase in continued mucin production, which will increase intraluminal pressure. That can collapse the low pressure venules, and thereby causing vascular congestion and predisposing to ischemia, as there is decreased venous outflow. There is going to also concurrently be increased bacterial growth inside the lumen, and that's going to cause an inflammatory process, generating and eliciting visceral pain. As the inflammation will spread to the serosa, we may also begin to observe a parietal pain, and there may also be appendicular artery thrombosis due to the inflammatory state, and the increase in pressure due to the bacteria can also cause a rupture of the appendix, and that can cause a generalized peritonitis shock, predispose the patient to septic shock. The risk factors for developing appendicitis can be broken down into modifiable and non-modifiable. The non-modifiable risk factors include age, and we observe a bimodal distribution where young teenagers have an increased risk, but also patients aged 40, potentially and over. And the other risk factors could be modifiable, and it could be low fiber diets, which can predispose to fecalith impactions. Smoking is another modifiable risk factor. What are the complications of appendicitis? Complications of appendicitis can be broken down into short-term, subacute, and acute. In the short-term phase in appendicitis, we may observe evidence of infection necrosis. We may also observe there can be rupture and generalized peritonitis, which can lead to sepsis and septic shock. We also have rupture, and this could go into the greater omentum, thereby causing potentially an abscess. There could be an abnormal there could be also a phlegmon that can grow there, and we may also get small bowel obstruction, which is very unlikely, but potentially also paralytic ileus may occur, predisposing to a small bowel obstruction. And then subacute causes could include, as we mentioned, abscess and phlegmon, and then long term we can get adhesions in the abdomen following appendicitis. And then what is the risk factors? We mentioned that complications. How would I manage this? Well, as the patient's going for surgery, first of all, the patient would be in pain, and especially if it's a peritonitic picture, they'd be writhing in pain. As a result, I'd like to give them pain relief. Could consider endone, possibly 10 milligrams to relieve the pain, and then I'd also consult with my senior, and then I could consider keeping the patient nil by mouth and on fluids. So I could consider maintenance fluids, maybe 125 ml per hour, depending on the patient's weight. And I could also then give antibiotics. So my antibiotics of choice could be ampicillin for gram-positive coverage, gentamicin for gram-negative coverage, e.g. E. coli, and then for anaerobic organisms, metronidazole. And yes, what are the surface and internal landmarks of the appendix? The surface landmark of the appendix is McBurney's point, which is 1/3 from the ASIS to the umbilicus. Internal landmarks are the tinea coli. There is a free anterior tinea coli and then a posterior medial and posterior lateral tinea coli. They all converge, giving rise to a blind-ended diverticulum that has a longitudinal smooth muscle layer. That is the appendix. We can identify the appendix surgically by observing for the convergence of all three tinea coli, or we can apply traction against the anterior free tinea coli. What is the vascular supply of the appendix? The arterial supply is branch of the superior mesenteric arteries. The appendix is a midgut structure. Particularly, it's going to be from your ilio arteries. There'll be the iliocolic artery, and one of its posterior branches will be the appendicular artery. And venous drainage will be the appendicular vein, which will then drain into the superior mesenteric vein, that eventually will drain into the portal vein. What are the anatomical landmarks separating the midgut? Midgut's 2/3 duodenum, greater duodenal papilla. Sorry, that's foregut. Midgut and hindgut division is 2/3 the way of the transverse colon. Vascular supply, celiac trunk, SMA, IMA, and the middle colic artery from the SMA will anastomose with the left colic artery from the IMA, thereby anastomosing. Supplying the entire large intestine. What's a neuroanatomical basis for pain? Neuroanatomical basis for the pain can be explained via the convergence projection theory, in which the visceral afferents will travel with sympathetic nerves to spinal segment dorsal root ganglion, and there'll also be convergence of somatic sensory fibers from a specific dermatome. In the case of appendicitis, or the appendix itself, the dermatome which provides sensory afferents at that spinal segment will be the T10 dermatome. And these will then travel via the spinothalamic tract to the primary somatosensory cortex. And in the case of pain, there'll be projection to the highly dense somatic nociceptor fibers, thereby causing an abdominal pain at the T10 dermatome. What are the possible positions of the appendix? The appendix can be the base of the appendix is well fixed and it's at the inferior margin of the cecum. However, the tail of the appendix can move around, and it could be retrocecal commonly, or it can be proileal or pre or post-ileal. If it's retrocecal, it can cause potentially a back pain, or it can be a lack of parietal peritonitis, as the appendix is not in contact with the anterior parietal peritoneum. There may also be a pelvic appendix, which can sit over the pelvic brim, and that can cause urinary symptoms. And there can also be a paracecal and a post-paracecal and a subcecal position. What are the nerves from L1? There is the iliohypogastric. There is the ilioinguinal and genitofemoral nerves, and they will supply different structures. For example, iliohypogastric could supply the abdominal muscles such as transverse abdominis. Your ilioinguinal can supply the base of the penis, the scrotum, and the genitofemoral can supply the thigh and also some reproductive structures. That's why genitofemoral. Come on. 6 minutes. We go through peptic ulcers now. Liz, that was a tough case. 49-year-old male academic. Was okay, 49-year-old male academic. Let's try doing this. 8 minutes. And how much time do I have? Yeah, look, 6-minute case, we'll do in 8 minutes. How if I reset this and make it a 6-minute timer? Let's go. 49-year-old male academic was admitted for the investigation of vomiting and diarrhea. No, I'll do it 8 minutes. Peptic ulcers. 49-year-old male academic was admitted for the investigation of vomiting and diarrhea over the past 24 hours. Reset. Okay, 49-year-old male academic was admitted for the investigation of vomiting and diarrhea, gastroenteritis in the past 24 hours. Last 3 hours he had noticed that his motions had been of a black and tarry nature. So, concerned about black and tarry stools. Melina. He had a past history of intermittent epigastric pain. On examination, the patient appeared pale and sweaty. Hemodynamic instability, a severe pain. Rectal examination revealed black liquid feces. So he's having melena, which is indicative of upper GI bleed. And he's tachycardic. He's very hypertensive. Oh my god, he's hemodynamically unstable. And he's afebrile, and he's got urinalysis is unremarkable. Okay, this is a medical emergency as the patient is currently in shock, and this can be observed through his very low systolic blood pressure and diastolic blood pressure of 70/50. I'm concerned about a hypervolemic cause of shock given the clinical picture of melena and upper GI bleeds, and I could look for, and this is likely indicative of hypervolemic shock secondary to some form of upper GI bleed. My provisional diagnosis for upper GI bleeds, given epigastric pain, could be gastric pathology. I am concerned about potentially esophageal varices if there is a previous history of alcoholic liver disease. Given the epigastric pain, my provisional diagnosis would be that of peptic ulcer. I'd like to exclude other causes of upper GI bleeding. Life-threatening causes could include esophageal rupture, so Boerhaave's. I'm also concerned about ruptured esophageal varices, which are also life-threatening. And other causes of upper GI bleeding could include generalized esophagitis, Mallory-Weiss tears, vascular pathology such as Guilfoy's or angiodysplasias. And then lower GI bleeds, I'm concerned about diverticular disease, malignancy, and angiodysplasia. What are your provisional differentials? Okay, what investigations would I order? I would like to order, well, the diagnostic investigation for an upper GI bleed likely is a scope, such as an endoscopic procedure. I could begin by completing bedside, possibly not much bedside. May not be any necessary investigations bedside. Then proceed to laboratory investigations, including full blood count, noticing any evidence of anemia, hemoglobin, which could indicate the necessity to transfuse the patient. Then we would consider a EUCs and LFTs. EUCs look for an increased urea to creatinine ratio consistent with GI bleeding, and LFTs to just look for any evidence of liver derangement, which could point towards a picture of cirrhosis and secondary portal hypertension, varices, and I could then proceed to completing a coags to look for any evidence of intrinsic coagulopathy that can contribute to the bleeding, which would be one of my differentials. And I could then proceed to consider a cross match if the patient needs a transfusion. Urea, I want to diagnose H. pylori, so I could do urea breath test and stool antigens for H. pylori and H. urea breath test to swallow radiolabeled urea, and H. pylori ureas can cleave the urea into ammonia, and we can detect the gas in a breath test. Serology, you can look for IgG. It does not help. Full blood count, coags, Griffin-Hold, and a chest X-ray. So if there is air under the diaphragm, so chest X-ray would be important in a peptic ulcer. If there is air under the diaphragm, we may consider a hemoperitoneuria, which can contribute to a GI bleed. Right. Possibly also liver function tests, while the stool is black, oxidation of hemoglobin during its passage, chemicals and bacteria, gastroscopy revealed a punched out ulcer in the pre-pyloric area. Right, describe the blood supply of the stomach. Right, so it's from the celiac trunk. There is your left gastric, your splenic, and your common hepatic. Your left gastric will give off esophageal by the left gastric branches. Just the left supplies the lesser coach for the stomach. Upper GI bleed. Splenic artery, which gives off your left gastric plaque. And your short gastric arteries, which will supply the fundus, and then your common hepatic will give off your gastroduodenal, your hepatic artery proper, and then off the hepatic artery proper can be your gastroduodenal will then break into your right gastroepiploic. Your splenic will also give off your left gastroepiploic, and that will also give off your superior pancreatic or duodenal. Right. So you can break it down into the fundus, which can be supplied via the fundus, which can be a lesser. There's a lesser curvature and greater curvature. Lesser curvature supplied by the left gastric artery, and you know what? Can finish that off after my 5-minute break. Alright, let's set what time it is now, all at 49, all at 50. Make 30 minutes and then a 5-minute break. How about that? Alright, so I know the branches, implicated arteries, duodenal ulcers usually affect the first part of the duodenum, posterior walls, the gastroduodenal artery, and the superior the pancreaticoduodenal artery. Right, gastric ulcers less commonly to erode, and they erode at the lesser curvature, so it's going to be the left gastric artery and its branches that will erode. And if it's a greater curvature, it's going to be a gastrocleploic. And if it's your posterior stomach, it's going to be a splenic, and there'll be major hemorrhage. Throughout the course of the splenic artery, tortuous path from the celiac trunk to the superior border of the pancreas, passes posterior to the stomach, and it reaches the spleen. Good enough for me. What are the posterior relations of the stomach and the duodenum? Oh man. Alright, there's greater momentum. I need to look at a diagram for this, otherwise I'm not going to understand it. Atlas, stomach and duodenum. Let's go, no, I don't want atlas actually. Let's get the models and let's get a focus model of the spleen. I don't want the spleen. Where do we go to the toes of the hump? Models, let's go back to models. I want the abdomen, and I want the arterial layer. I don't want the lymphatics. And sure, so that's the abdomen for you. That's the umbilical ligaments, paraumbilical ligaments. The question is, what are the posterior relations of the stomach and the duodenum? So I should be able to close my eyes and see the stomach. Well, what's the anterior relation? So this is your greater sac right there between the abdominal wall and there is the supracolic and your infracolic recess, and that makes sense. And that should be your ligamentum teres. So falciform ligament there, but that end should be ligamentum teres. Or the round ligament, or ligamentum teres, yeah. Falciform ligament. Okay, so posteriorly we should have, well, superiorly we have the hemidiaphragm, so the left side. We have the lower esophagus, the esophageal hiatus. Esophageal hiatus. I'm feeling a color change out here. Let's change this entire room from purpley to yellowy. Not white, not orange, maybe a bit more orange, maybe a bit red. Yeah, I like that. Oh, pink looks good. We'll do pink. Lower the brightness further. That's too bright. Okay. It's a bit better. If I dim this a bit more. Dimmest it can be. Okay. Hiatus is the opening of the diaphragm through which the esophagus passes, and it's situated at the level of T10, and that's because the esophagus, esophagus, esophagus is 10, so it's T10. Aorta is T12, IVC, diaphragm level, T8. IVC, inferior vena cava, is T8. Your aorta, your esophagus is T10, and your T12 is your aorta. Right, and your esophagus. Okay, that makes sense. Okay. Right. T8. So let's see what this question is. Okay. Esophageal hiatus. Where is the hiatus? We'll climb up. Go around. Yeah, should have been to that. It goes into the stomach, which is interesting. Right. Your liver's on the right side as such. Bulges out. Your esophagus. Anterior relations. Stomach. Superior, inferior secretor omentum. And you have your colon as well, right? Your transverse colon, and your pancreas is posterior to the stomach. It's a bit of a deeper structure. And posterior is your splenic artery, your tail, your pancreas. Yeah, you can see the head of the pancreas, not where the stomach is. It's the tail of the pancreas, and the tortuous splenic artery right there. Bang. There you go, it travels the superior border of the stomach, and what I maybe can do is zoom through. Oh lord, you zoom through structures. Oh my lord, I'm shocked. So right now I can see the splenic artery, right? Like that. That would be your... Let's remove your gastrohepatic. We'll zoom out a little bit. What is a gastrohepatic relating to? We'll zoom out a bit more. Your gastrohepatic links your... Let's turn it around. Right. We'll zoom in through the aorta. Right, so it links your liver. Right, what is that? It's your liver. Yeah, that's your hepatogastric. So when you move past the hepatogastric, that's when you will see the actual branches right there. So there's your splenic. That would make that your left gastric, and that would make that your common hepatic. Beauty. It's absolutely beautiful. Holy crap. Alright, and then if I want to travel down and follow that artery, so that's your common hepatic, and that will be your gastroduodenal. And the gastroduodenal supplies your superior pancreatic or duodenal. So we'll travel down and follow that. And that should be your superior pancreatic or duodenal. No, your left, yeah. Superior pancreatic or duodenal. What about this one? It should be your gastroduodenal. What's this? Duodenal branches, yeah. It's just duodenal branches. Then travel to the duodenum. And what's this? Right, gastromental artery. Yeah, we'll just remove gastroduodenal. Where's your right gastroepiploic? So that is your right gastroepiploic. No, it's the posterior. And that would be your gastroepiploic, right? Where's your gastro? Like that. Splenic artery, the lesser sac, well, the greater sac is between, it's the transverse mesocolon and the greater omentum. So your transverse mesocolon, your lesser sac. Your lesser sac is formed posterior to lesser sac boundaries. To lesser omentum. Space posterior lesser between the posterior wall of the stomach and the surface of the peritoneum that covers the anterior surface of the kidney. There's only natural communication between the lesser and greater sacs. Boundaries, here's the... Okay, it's your peritoneum that's over. It's the anterior surface of the kidney. So, to make sense of this, your lesser sac is from your gastro... Right there is your gastro... That's your gastro... hepatic. Posterior to this, if I zoom out a little bit and I just travel posterior, everything between that and the foramen of Winslow is that small pouch. Between the greater and lesser sac. So the greater sac is the anterior abdominal wall and the transverse mesocolon, and that would make the hepatogastric and gastrohepatic ligaments form the foramen of Winslow, and there is the whole, I believe it's the aorta is behind it, and it's your lesser curvature of your stomach, your aorta, posteriorly, the venous. Let's turn the venous system on and see which one is right behind it. Epiploic foramen. Here's the vena cava. It's also your aorta. It's your aorta and inferior vena cava in your common bile duct. The gallbladder should also be there. Okay, so if we turn it over, yeah, the gallbladder is also there, right next to it. Right, leftmost region, and that's the epiploic foramen. Yeah. Greater omentum boundaries. So posteriorly is the lesser curvature of the stomach, anteriorly is the liver, and then you have your omentum, then your IVC behind it. Travels in there and stuff. Climb the patagiodinal ligament. Pringle maneuver. Supracolic and infracolic, and the greater omentum is the space between the anterior abdominal wall and the transverse mesocolon. Space between transverse mesocolon and the anterior abdominal wall is the greater omentum. That's your intestines, and that would be your posterior, that's your greater omentum. That's the transverse mesocolon, so I would make that the transverse colon, so that's his stomach, and that would be the greater omentum. The space encased between the lesser foramen of Winslow, so lesser sac, there is the infracolon compartment, transverse mesocolon, so it's a greater omentum and the transverse mesocolon. That makes sense. Now I finally understand that. And relations, and then you have your lesser sac posteriorly to the stomach, all that space. You have your left kidney and the spleen. Where the spleen at? Spleen where you at? Should be right there. These men don't have a spleen. And then there is your first, second, and third part of your duodenum. Oh my god. That's gonna be hard. To peptic ulcers, relations in the duodenum. You've seen an anatomical diagram to understand this, right? That diagram's really good. Copy the link. So there is your D1, D2, D3, D4. So the duodenum kind of shifts in that shape. If I had to have a anatomy diagram. Right, D1, D2, so it's horizontal duodenum. Let's see how that makes sense. Yep, this is D1, which comes off the stomach. And your pancreas is posterior. And then D2, D3. Let's get rid of this guy. Let's fade it. Fade. What part of fading do they not understand? Right, so that's the D1, D2, and you can see your arteries, your superior mesenteric, your SMA running anterior to that. So D1 is the first 2 point, so the superior part descending. D1. Duodenum. D1. What is the posterior relation of the stomach and the duodenum? D1 and D2, it's the right kidney and suprarenal glands. 2 is the right kidney and your ascending colon. D3, anteriorly is your superior mesenteric artery, posteriorly the head of the pancreas encased. The second part's the right kidney. IVC. Is IVC posterior to any part of the duodenum? Let's see. Yeah, it's posterior to the first part, yeah. Your IVC and your aorta is posterior to the first part of the duodenum. So is that's it. Visualize this. IVC and your aorta. What the hell are those? IVC aorta is your right kidney and your liver is also posterior. Definitely is posterior. Your liver, what is anterior? Yeah, it's mostly anterior. Look, it is. And then your gallbladder is also anterior to the first part of the duodenum. So you're just sitting like a sack over there, first part of the duodenum. Second part is your right kidney. Third part, SMA is anterior. And again, whatever is anterior. So IVC and abdominal aorta. What else did we say was posterior for this? D1, nothing. Neck of the pancreas. Yep. D1, common bile duct is also posterior. Gallbladder is anterior, so is the lower lobe of the liver. Right kidney, your hepatic flexure is anterior to D2. D3 is your SMA, your IVC aorta. And then fourth part is your root of your mesentery. Yeah, there'll be mesentery. And there'll be jejunum anteriorly. Jejunum, is that jejunum? Is that jejunum? It's just going to be called small intestine. It's your ileum there. It's on the right side. And that's your jejunum. Look, you can just see your ileum and your jejunum. You can't really tell. Oh no, the fourth part is ascending, so it is definitely jejunum. Yeah, that's your jejunum. So duodenum, jejunum, and ileum. Posteriorly will be mesentery. Oh, that's hard. A lot to remember. And posterior, esophagus, hiatus, greater omentum, lesser sac, splenic artery, tail of the pancreas. Splenic artery, tail of the pancreas, left kidney, adrenal gland, spleen, It's a left-sided structure. It's a left-sided structure. What are the complications? Can be GI bleeding, can erode vessels, anemia, hematuria, if it's a splenic artery. They erode into vessels, they can perforate, they can bleed, they can perforate and spill contents into peritonitis. It's seen in duodenal ulcers, posteriorly in duodenal ulcers. Gastrical, duodenal ulcers and posterior gastric ulcers dependent. And recurrent ulcers, scarring and fibrosis, and early satiety. Pyloric obstruction, you get fistula abnormal, so penetrates high thickness of wall to energetic and form fistulas. Chronic, and you can increase your risk of malignant malt lymphomas from ulcers. The malt lymphomas, PPIs, H. pylori, triple therapy for gastric ulcers. It's PPI, amoxicillin, clarithromycin, PPI, esomeprazole, or omeprazole, 20 mg orally twice daily for 7 days. 20 mg orally TD for 7 days. Amoxicillin, one gram orally twice daily, and clarithromycin. Clarithromycin is the 50S ribosomal subunit inhibitor. Amoxicillin is subwall. I'm not remembering everything else, just PPI, right? It's most commonly caused by NSAIDs, smoking, stop smoking, stop NSAIDs, H. pylori. Alright, done. How much time we got? 3 minutes. Let's see if I can answer this case really quickly. We'll do pancreatitis, and then I should probably call it to... Can't be that ambitious, Prithvi. You've done 2 cases. You can't expect... No, we'll do the 3rd as well. And we'll do the 4th. So much anatomy for the GI tract, man. So much. What about path? Diagnostics, anemia, alcoholic liver disease. It's so fat. What about path? Colorectal carcinoma, cholecystitis, IBD. Oh my lord. Farm, alcoholic liver disease, peptic. Holy. How's endocrine? How's psych? I haven't done any psych cases at all. Farm, schizophrenia, and depression. Not bad. That's all I'm doing for psych. That's small. What about rheum? Rheum is fucking huge. What about genitourinary? Yep. And obstetrics and gynae. Path. Oh my lord, it's so much. So much to do. Peptic ulcer. 49-year-old male academic who was admitted for investigation of vomiting and diarrhea. In the last 3 hours, he had noted motions that had been black and tarry. He had a past history of intermittent epigastric pain. On exam, he appeared pale and sweaty with tenderness in the epigastrium. Rectal examination revealed black liquid feces. He's hemodynamically unstable. He's in shock. My provisional diagnosis is that of hypovolemic shock secondary to a source of upper GI bleeding, most likely a peptic ulcer given the epigastric pain. I am suspicious of a upper GI bleed due to the presence of melena and diffuse epigastric pain in the history. And peptic ulcer is likely given the past medical history of intermittent epigastric pain. I'm concerned that the peptic ulcer has perforated and resulted in rupture of an artery, and as a result we've seen hypovolemic shock evident through the low diastolic and systolic blood pressures. Vital signs are otherwise normal. He is tachycardic, which could be a compensatory response. Other differentials could be other life-threatening causes of abdominal pain. I'd like to exclude mesenteric ischemia, more likely in older age groups, potentially also vascular pathology such as abdominal aortic aneurysms, and then other causes of GI bleeding could include esophagitis, esophageal varices, Mallory-Weiss tears, ruptured esophagus, and then gastric causes including gastritis, gastroenteritis, peptic ulcer as mentioned, and then malignancies and duodenal ulcers, and vascular causes such as angiodysplasia and Guilfoy's. What investigations would I order? Well, the diagnostic investigation would likely be endoscopy, looking for the source of the bleed, whether it be a variceal bleed in the esophagus or a peptic or duodenal ulcer. I would like to also do a bedside. The bedside, I would not do any investigations as of yet. And laboratory, I would do a full blood count, EUCs, full blood count looking for hemoglobin and any anemia which could prompt transfusion if hemoglobin is less than 70, and then I could consider EUCs looking for a raised urea to creatinine ratio. I could then proceed to do LFTs, look for any evidence of liver disease that could predispose to portal hypertension, coags, and given that I do suspect this is a peptic ulcer, I could do a H. pylori urease test. This might be done in the GP follow-up setting, if not in the emergency department. And I could also do and consult for gas endoscopy. If I'm unsure regarding the pathology, I could also do a CT scan of the abdomen. And potentially bedside ultrasound may be useful in looking for free fluid. Okay, why was stools black? Well, there's oxidation of hemoglobin 1 by enzymes in the GIT and also bacteria, and that causes the hemoglobin to take on a black appearance. This is indicative of an upper GI bleed. The punched out ulcer in the pre-pyloric region describe the blood supply to the stomach. Okay. Okay, so this appears to be a gastric bleed. Gastric bleeds, the bleed depends on where the ulcer is. So the stomach can be divided into the fundus, the lesser curvature, greater curvature, and the pylorus going into the duodenum. The fundus of the stomach is so the entire stomach is supplied by the celiac trunk, and there are 3 branches to the celiac trunk. There is the left gastric artery, the splenic artery, and the common hepatic artery. The short gastric artery will give off branches to supply the lesser curvature, whereas the splenic artery will take on a more tortuous route and give off the left gastroepiploic artery, supplying the left side of the greater curvature, but also the short gastric arteries that will supply the fundus, and therefore a fundal bleed could perforate those vessels. A posterior stomach bleed could perforate the splenic artery, which could lead to major hemorrhage, and we may also observe the the left gastric artery implicated if it's a bleed at the lesser curvature. And then the pylorus can be supplied by branches of the gastroduodenal artery, such as the superior pancreatico, branches of the gastroduodenal artery. Describe the course of the splenic artery. The splenic artery begins at the celiac trunk. It will take on a tortuous path that is along the superior margin of the pancreas, and it will then innervate the spleen prior to giving off vessels. Prior to this, it gives off branches including your left gastroepiploic and also your short gastric arteries. What can I see? Just happened. Gastroscopy revealed a punched out ulcer. Yep. Posterior relations of stomach and duodenum. The stomach is a foregut structure, and it's located at the left side of the abdomen and peritoneum. Posteriorly to the stomach, we have the pancreas. We have the splenic artery that travels with the pancreas. We also have the left kidney. And we have the aorta and the lesser sac, with the aorta, the inferior vena cava, and then to the right we can also have the common bile duct. The duodenum's posterior relations depend on which part of the duodenum. There are 4 parts. D1's posterior relations include the gastroduodenal artery, the common bile duct, the aorta, the inferior vena cava, and the second part of the duodenum will then travel down posteriorly, and its posterior relations could include the fourth part of the duodenum has the jejunum anteriorly and the base of the mesentery posteriorly. Third part will also have aorta IVC, and the second part of the duodenum would have posteriorly not have colon. Right kidney. It's a bit lateral, and will travel anterior. So right kidney, which is what I forgot. What are the complications of gastric ulcer? Hiatal hernia. Right. And then, what are the complications of gastric ulcer? Gastric ulcer may perforate an artery. It may result in gastric bleeding. It may perforate the actual viscus, resulting in spillage, generalized peritonitis. Mostly, it can be seen in posterior duodenal. It can form a fistula, in which we have an abnormal relationship between the duodenum, for example, and other structures such as the pancreas. And we may also get obstruction due to chronic ulcers, fibrosis, and outlet obstruction. Most commonly occurs at the pylorus, perforation, GI bleeding, perforation. Also can erode into vessels, and get perforation. We can get obstruction due to multiple ulcers, and we may get fistula formation. So we may get erosion of the ulcer into a vessel, erosion into the peritoneum, erosion into another organ, causing a fistula, and also multiple bouts of this can cause scarring, fibrosis, and pyloric obstruction. Chronic effects, mailto lymphoma is what I'm concerned about. Carnifex, melt, lymphoma. How do you treat this? Recurrent gastric ulcers. Most common causes are your H. pylori detected through the urease test, and then your H. pylori, NSAID, and smoking. You can seize the NSAIDs. We can behavior minimize. We can manage the smoking through counseling and pharmacological, non-pharmacological mechanisms. And we can manage the H. pylori with a triple therapy, including proton pump inhibitor, amoxicillin, and clarithromycin. And 2 proton pump inhibitors? No, it's one or the other. PPI, amoxicillin, clarithromycin. We're not doing all of that. Which has PPI, amoxicillin, clarithromycin for H. pylori. Alright, now I take my 5-minute break. completely, I forgot. Oh, thanks for reminding me. Alright. Yeah, I was doing a lot of talking, so just coming back to this case. Given the presence, okay, start again with this case, middle-aged alcoholic man. I'll quickly look through the answers as well to see whether I can just quickly go through this one. So, yeah, acute, alcoholic, right upper quadrant, gradual epigastric, right upper quadrant, radiates in a band-like way, leaning forward, nausea, vomiting, is guarding, is Collins sign, Gray Turners, there is hemorrhage, bowel sounds may be quite absent due to paralytic ileus, didn't mention that. Rebound tenderness and guarding, esophageal, pancreatic, cholestasis, hepatitis, small bowel obstruction. Why am I not thinking small bowel? I missed it twice. MIs. Why are you so sure it's chronic pancreatitis? Pain is dull. Is to the back, usually 30 minutes postprandial. Smashed. Gallstones. I get smashed. Gallstones, idiopathic gallstones, ethanol, trauma, steroids, mumps, malignancy, autoimmune, scorpion sting, hypertriglyceridemia, hypercalcemia, ERCP, and drugs. I get smashed. It can be idiopathic gallstones, ethanol, trauma, idiopathic gallstones, ethanol, trauma, steroids, mumps, autoimmune conditions, scorpion stings, hypertriglyceridemia, ERCP, and other drugs, azathioprine, Bactrim. So what's the mnemonic? I get smashed, idiopathic gallstones, ethanol, trauma, scorpion, mumps, autoimmune. We have the S. H is hypercalcemia, hypertriglyceridemia. E is ERCP. D is drugs such as Bactrim, antibiotic, azathioprine. What is the second S? Steroids and scorpion. Steroids, we got steroids. I get smashed. Idiopathic, gallstones, ethanol, trauma, steroids, mumps, autoimmune, scorpion sting, hypercalcemia, hypertriglyceridemia, ERCP, drugs such as azathioprine and Bactrim. Done. Not that hard, is it? Pain is dull, radiates to the back, postprandial, stones, stools are loose, family history, and smoking. So smoking is a strong risk factor, so I'd like to get smoking history, but there's likely nausea, vomiting, but it's usually non-specific. So weight loss takes months. Calcification on x-rays and CTs would be chronic recurrent bouts. What would you collect from history and exam? Yeah, it's upper quadrant, left upper quadrant, to the back, up sitting, bending forward. Pain is rapid, reach maximum intensity in 10-20 minutes. Pain is localized, and onset of pain is rapid. 10-20 minutes. Other causes have a slow onset. So if it's a rapid onset, I'm concerned about gallstone pancreatitis, nausea, vomiting, and get a family history indicative of chronic pancreatitis, gallstones, alcohol, trauma, steroids, autoimmune, examination, shallow breathing from diaphragmatic irritation. It can be a pancreatic or pleural fistula. Pancreatico pleural fistula. Holy Pancreatico pleural fistula can cause a pleural effusion in pancreatitis. Some might do a recipe exam. There can be a transdiaphragmatic lymphatic blockage, pulmonary edema from the alveolar capillary membrane. Holy sheesh. I can't remember all of that. It can be pleural effusion because of inflammation can irritate the pleura, cause pleural effusion. Abdominal examination can be jaundice from obstruction of the common bile duct. I forgot that. So if you had a pancreatitis obstructs the common bile duct, how would that happen if there's a gallstone? Gallstone pancreatitis, possibly. Murphy sign, negative. Collins, Gray Turner's, Murphy's. Muscle spasms, Willett differentials, investigations which you perform, lipase and amylase. So let's go back to a nat and open up pancreatitis. This is such a fat case. Case history, mild epigastric pain, pancreatitis, chronic cystic fibrosis, neoplasm. Why is it diarrhea? This fibrosis of the pancreatic parenchyma, this functional acid and mass. There's exocrine insufficiency, decreased secretion of lipase, protease, amylase, and there's inability to break down the molecules, it's steatorrhea. So, reduced amylase secretion, osmotic gradient across, drags water, and you also get loose stools. So why do you get a diarrhea in pancreatitis? Number one, it's due to the exocrine insufficiency, decreased acinar functional mass, and that leads to decreased release of lipase, amylase, proteases that otherwise should break down the secretions in the intestines, break down the food, doesn't get broken down, and that causes a steatorrhea. Number two, the carbohydrates can act as an osmotic. It can increase the osmotic gradient and draw water into the lumen. Why is there weight loss? Yeah, because it's malabsorption, right? Yeah, energy deficit, yep. There's food avoidance because it triggers the pain. What is a pathogenesis? Underlining this x-ray. This man has 3, what is that, like clips? But there is also calcification of the pancreas, and you can see that. Repeated attacks, there's fibrotic change, and there is proteinaceous secretions, free precipitating with calcium. It's free fatty acids precipitate with calcium. Calcium due to calcium proteinaceous secretion. So there's enzymatic fat necrosis of the pancreas and the release of free fatty acids that can precipitate with calcium. And this is deposition of the salt that occurs in necrotic areas. So in recurrent bouts of pancreatitis, there is fat necrosis of the pancreas, and that free fatty acids can precipitate with calcium. Calcium can accumulate in necrotic areas of the pancreas and give rise to calcifications on X-ray. Yep, there's chronic fibrosis, and chronic fibrosis in the head can lead to obstruction of the bile duct, can it? Lead to obstruction of the bile duct. So that's the head of the pancreas. Yep, right. That is the duct. You squeeze that duct and you're gone. That's because the main pancreatic duct is traveling across here as well. So that makes sense. Oh, shit. What did I do? Zoom out. I don't want to see that much. That's all I want to see. Okay, why did he develop jaundice, an obstructive jaundice and pancreatitis? Because the pancreatic head can fibrose and obstruct the common bile duct. Ah, that makes sense. CT. Identify the right kidney, the portal vein, duodenum, gas in the stomach, pyloric valve. So that's your rectus abdominis, right? 17. What is number 1? That should be... Okay, so this is an axial CT. It's non-contrast. As we see that the bone is lit up. The liver is on the right-hand side. Rectus abdominis anteriorly. We can see the abdominal wall muscles here. That would be your transverse abdominis. External internal oblique transverse abdominis. 19 is your latissimus dorsi. Okay, it's your lats, yes, alright. What's number 1? We said it's your right lobe of your liver. That makes sense. The left lobe would be there. What is number 2? Well, what is this structure here? We'll start with that. 10, I would say, well, 12 is slightly to the right, 10 is to the left. 10 should be aorta, right? Yep. And then to the left, that should be your IVC, right? 12. Yep. And then your portal vein should be anterior to the IVC. Portal vein is formed from the SMA and from the splenic vein. And so the 3 is your splenic vein going to form your portal vein, which should be 4. No, 4 is head of the damn pancreas. And what's 2? 2 is a portal vein. 3 should be your splenic vein. So your splenic vein traverses and then combines with, splenic vein combines with the splenic vein combines with the superior mesenteric vein to form the portal vein. Head of the pancreas. 6 is your small bowel. 7 is your hepatic flexure. Where's 7? That's colon. 8 is your descending colon. No chance, I don't know. So it's spleen, kidneys, aorta, superior mesenteric. 12 is your inferior vena cava. 13 is your left adrenal gland. Where is 13? I can't even see that. The cortex, pyramids, rectus abdominis, rectus spinae. 20. 19 is your latissimus dorsi. 18. That should be 18. That makes sense. Latissimus dorsi is way more posteriorly. Alright, and then acute pancreatitis. 40-year-old presents with intermittent epigastric pain. She's had recurrent symptoms, gradual onset, not severe, and her blood pressure is also low. Provisional is shock secondary to acute and chronic. Concerned about pancreatitis, peptic ulcer disease, cholecystitis, hepatitis, bowel obstruction, perf. So epigastric, you always think pancreatitis and bowel obstruction and perf, but also lower MI. And your vascular pathologies in a woman, you consider your ectopic pregnancy, your torsion, your pelvic inflammatory disease, all of that. It's diagnosed with 2 of the following criteria. That's what we need. 2 of the 3 criteria for pancreatitis. We need clinical findings, imaging findings, lipase. Any 2 or 3 are positive, you've got pancreatitis. So what investigations would we perform? We perform a lipase, we do a CT, and we'd also look at clinical findings. ECG, ultrasound, for gallstones, do a blood sugar. Yeah, you'd want to do a blood sugar in pancreatitis. It's very interesting. Bloods, lipase, LFTs, CMP, as they can be hypercalcemia, enzymatic fat necrosis, decreasing free calcium. That's pretty crazy. And CT, pancreatic abscesses, is the most useful. and typically follow up with ultrasound to MRCP through the biliary tree for gallstones. Chronic pancreatitis is almost always alcohol. Acute pancreatitis is eye gets smashed. Idiopathic, gallstones, alcohol, trauma, steroids, mumps, autoimmune conditions. We said steroids. We said we didn't say the ERCP and drugs, and scorpion stings was another weird one. And then H is hypolipidemia or hypo and hypercalcemia. And then pathogens, what's a pathogenesis? Premature activation of proteolytic enzymes, pancreatic zymogens that causes autodigestion. There are three main mechanisms. Pancreatic duct obstruction, acinar cell injury, defective intracellular transport. There's some kind of pancreatic duct obstruction. There is acinar cell injury, and that causes inappropriate activation of proenzymes, and that causes an inflammation, proteolysis, fat necrosis, damage to the vessel walls, and that can cause a hemorrhage. Whereas gallstone pancreatitis, ampulla vata, and that can cause retrograde flow and activation of pancreatic enzymes, and that leads to proteolysis, fat necrosis, damage to the vessel walls. So the basis here in the pathophysiology of pancreatitis is there's usually some kind of obstruction or damage to the pancreas and activation of your proenzymes. And these are your pancreatic zymogens, and this could include trypsinogen or chymotrypsin. Trypsinogen, chymotrypsin. Yeah, so there's a lot of enzymes, but there's enteropeptidase. They'll inactivate trypsinogen to trypsin. There's enteropeptidase. There's enteropeptidase in the small intestine. So normally enteropeptidases in the small intestine will activate your trypsinogen into trypsin, and that activates all the other enzymes like your chymotrypsin. We'll just take that enterokinase. Copy image and paste it. Okay, what are we seeing here? Should be your aorta. We're at the level of the pancreas. That should be your celiac trunk, and that should be the pancreas. There'll be some fibrosis. Kidney, possibly your portal vein, IVC, gallbladder, stomach. What did I get? Duodenum? No. I said that was possibly portal vein. Did I? Stuff that up. It's duodenum. That was your pancreas. And shaggy margins. And there is peripancreatic infiltration. Right. Obstructive jaundice. What are the complications? And then clinical findings, and then normal pancreatic activation type toggle. Right. What are the complications? You can get hypertension, hypertensive shock due to third spacing. What is third spacing? Does that mean you just get... Third spacing is when you build up fluid in the body in a body compartment which doesn't normally have fluid, and that could be, for example, in bowel obstruction, you can get third spacing that causes fluid to build up in the actual wall of the bowel, right? But third spacing in pancreatitis, in the peripancreatic region, so just around the pancreas, because there's going to be massive hemorrhage. So third spacing is just a funky way of saying that there's all this fluid building up and hemorrhaging in the pancreas. Okay, there is shaggy margins of the pancreas. You can see peripancreatic fat. You can see fat stranding, calcifications. Okay, what else we got here? Some kind of activation, inappropriate activation of proenzymes such as trypsinogen. Right, alcohol leads to secretion of protein-rich pancreatic fluid that may participate and obstruct. Chronic alcoholism can increase the protein-rich fluid that may obstruct the ducts. Repeated exposure. So acetaldehyde is an acetotoxin, and there can be acidocyl injury and premature activation of trypsinogen to trypsin. And this leads to lipases, fat, and elastases, which leads to blood vessel hemorrhage, and procarboxypeptidase, which leads to autodigestion, proteases, proelastases, lipases, fat necrosis. And oh no, that is the best diagram. Why was I even copying all these other silly ones? Come on, Key. Tell me you got this. What is the pathophysiology for hypertension, hypovolemia, as the collection of fluid as the pancreas auto-digests itself, peripancreatic collection of fluid. This is the main mechanism, so third spacing, where we get peripancreatic fluid collection as the pancreas auto-digests itself, and there is also edema due to increased capillary permeability. There's inflammatory response, damage to vessels, and there is also peritoneal fluid loss and sequestration fluid. It can also be gastrointestinal ileus, which can cause sequestration of fluid in the bowel lumen. This is a common event in acute pancreatitis. And renal failure. Rehydration is vital, and that's why you need to monitor urine output, as you can get hypovolemia due to third spacing, peripancreatic fluid collection, changes in microcirculation that lead to endothelial function and edema. So the endothelial permeability is the peripancreatic fluid collection of the pancreas digests itself. And finally, there is also associated paralytic ileus, which causes fluid to build up in the bowel lumen. How do you manage the patient's condition? IV access fluid resus. You need to measure the fluid output, as they're hypovolemic and get renal failure. Antibiotics for about 7 days if febrile, jaundiced, and the cholangitis predicted severe disease or confirmed necrosis, acute necrosing, prophylactic meropenem, beta-lactam antibiotic prophylaxis. We can give beta-lactam antibiotic prophylaxis. Let's just see what ETG has to tell us, man. Oh, so much. HEF, pancreatic empirical therapy of pancreatic necrosis. Surgery. Initial management of acute pancreatitis, just fluid administration and analgesia. There's an ascending cholangitis, you may need surgery. And antibiotics generally not indicated. And inadequate resuscitation. Hydration is a common cause of morbidity. Early aggressive hydration is beneficial. 500 ml bolus, ml per hour. Analgesia, morphine or fentanyl, antiemetics, early cholecystectomy, oral intake 6 monthly, and then severe. There's organ failure, severe. Okay, so if you have necrosis, infected pancreatitis, then you could consider the piperacillin and tazobactam. That's what management, let me write that. Normal management of pancreatitis. We'll get Key's notes up too. You manage the patient's condition. And for that, we would say acute pancreatitis. Antibiotics. Antibiotics not indicated. Fluids. Give the patient bolus 400 ml per hour. And normal saline. And monitor. Status. Fluid balance charts. Balance charts. Antibiotics not usually indicated. Not indicated. Analgesia is the other thing. And for analgesia, we will use morphine or fentanyl. Morphine dosages. 2.5. Same for endone, right? Morphine dosage. We get a complication, e.g. acute cholangitis. wanted. Principles, inadequate hydration, analgesia, dosages, and precautions. Chlorazepine on ondansetron, analgesia. Yep, analgesia. Fentanyl. Morphine mics, 1 to 2 milligrams IV. Endone. Endone is oxycodone. Yeah, the oxycodone, 1 to 2 milligrams. 1 to 2 milligrams. Morphine, 10. Doses. So you don't want to exceed morphine or oxycodone. Similar dosages in fentanyl, 300 mics. So you usually give them 30 mics. You get 1/10 of that dosage, 1 to 2 milligrams. Fentanyl, 30 mics. Drug dosages, 1 to 2 milligrams. Give them 1 to 2 milligrams. Do not exceed 300 milligrams. Wow, so good. ETG is the lifesaver. ETG is the Bible. Right, and so severe oral intake, mild oral intake may not need to be ceased. Fasted oral intake may be reduced as tolerated. Gallstone. Gallstone, pancreatitis, uveitis. Surgical intervention may be warranted. Okay. Became hypertensive, hemorrhage, elastase, increased inflammatory vasodilation, increased permeability, third space, loss of fluid around the pancreas, and other structures such as the lung, peritoneal cavity, ascites. Use inflammatory agents which causes pleural effusion, hypertension, irritation of the bowel, paralytic ileus, worsening third spacing, and fluid loss can occur via emesis. Hemorrhage in third spacing is the cause of hypertension. And electrolyte abnormalities, hypocalcemia, hypoglycemia, and hyponatremia and chloremia. Yep, that makes sense. And there's medication. Measure the patient's condition, fluid, right. So what are the complications? It can be shock, hypocalcemia, shock, electrolyte abnormalities, ARDS, pleural effusion, be a pancreatic pseudocyst, rupture of the pancreatic duct, the abscess, rupture of the pancreatic duct, fibrous crepes will resolve, the pancreatitis reabsolve, it can be GI bleeding, GI gastrointestinal complications, immediate delayed, it can be an abscess and pseudocyst, So acute, there may be electrolyte derangements, it can be hemorrhage, third spacing, hypertension, ARDS, and then complications, increased risk of pancreatic cancers, it can be GI bleeding due to enzyme, yep, it can be thrombosis, vasculature, it can be obstructive jaundice, it can be diabetes, it can be osteoporosis, malabsorption. Chronic can be diabetes, malabsorption, and cancer. Diabetes, malabsorption, and cancer. Diabetes, malabsorption, and cancer. Diabetes, malabsorption, and cancer. Might they obstruct? Can be shaggy margins, peripancreatic fat stranding. There can be significant atrophy of the pancreas, calcifications. Ooh. Oh my lord. Shall we do this station and then I'm done? I'm gonna take a quick minute break and then we'll do this one case of pancreatitis. That means I've only done peptic. Oh, I've done 3 cases, which is not bad, but it took so long to study. Alright. I'm gonna give it 1 minute and then I'll come back to this station because that was a fat case. Just give me 1 minute. Alright, let's go. Last sesh. And I'm done. I got a raging headache too. Alright, a middle-aged alcoholic man presents to ED. Let's time this as well, see how I go. Holy crap. That's not what I wanted. Much better. Ain't nobody got time for that ugly ass sign. Alright, let's go. Middle-aged alcoholic man presents to ED. My provisional diagnosis is that of shock given the presence of marked hypotension. It is likely due to hypovolemic shock, and this could be secondary to an upper GI bleed or pancreatitis. My differential diagnoses would be the other cause of upper GI bleeding. Given that he's an alcoholic, I'm concerned about Mallory-Weiss tear, esophageal ruptures, potentially gastric varices. I like to exclude peptic ulcer disease as another cause of GI bleed, and then there are lower GI bleed causes such as diverticular disease, angiodysplasia, and colorectal cancer. Other causes of epigastric pain could include abdominal pathologies, as cholecystitis, could be an acute hepatitis. We've mentioned pancreatitis, and other life threats could include abdominal aortic aneurysms, aortic dissection, and I'm also concerned with bowel obstruction. So why am I sure? Could it be chronic pancreatitis? Yes, I am concerned of an acute on chronic pancreatitis, given the fact that he's had multiple episodes in the past, and this can increase your risk of subsequent bouts of pancreatitis. The risk factors here, he's alcoholic, and that's one major risk factor for pancreatitis. He's got loose stools, and steatorrhea is a common complication of pancreatitis, and weight loss indicates that there has been malabsorption secondary to chronic pancreatitis. I can also see there is no hepatosplenomegaly, so that rules out other major differentials such as alcoholic liver disease and varices. What other history and exam findings would I collect? With actual history, I'd like to characterize the type of abdominal pain. I'd like to determine whether it changes with meals, posture, which is characteristic of pancreatitis. It usually exacerbates 30 minutes postprandial, and it is alleviated by sitting upright. And I'd like to also characterize and exclude differentials. So sudden onset pain could indicate potentially some kind of rupture. I'd like to determine whether it's been tested for H. pylori before, whether there's been any hematochezia or hematemesis, which could point towards GI bleed, and then past medical history, any medications that are being taken such as corticosteroids, NSAIDs, anticoagulants that can predispose to bleeds, in peptic ulcer for example. And I would like to also look for any medications such as antibiotics, azathioprine associated with pancreatitis, family history. I'd like to for any evidence of any liver disease in the family. Psychosocial, I would do a cage questionnaire, counsel the patient. On examination, I would see evidence of a I forgot to start my timer. See evidence of guarding, rebound tenderness, rigidity. Guarding, I'd see evidence of guarding, rebound tenderness, which could indicate a peritonitis secondary to the pancreatitis. I may also observe evidence of pancreatic hemorrhage, such as Cullen's sign, where we see periumbilical ecchymosis, or Gray-Turner's sign, in which we observe flank ecchymosis. There's also other sites of ecchymosis, such as Fox's and Bryant's sign, where there's scrotal ecchymoses. And I would like to also test for, given that he's middle-aged, I'm not too concerned about appendicitis, however I could quickly do Rovsing's test and also Murphy's sign to rule out any evidence of cholecystitis by looking for pain on inspiration when palpating the right upper quadrant. Okay, and I may also notice bowel sounds are decreased as we can see a paralytic ileus secondary to the pancreatitis. I've also managed that. What investigations would I perform? Bedside, I might like to do an ECG just to rule out MI, given that he is complaining of epigastric pain. I would also like to get a blood glucose level, as this may be altered or deranged if there is pancreatitis, especially chronic pancreatitis. We may observe some endocrine failure of the pancreas. I could also do urinalysis, look for any renal causes of this abdominal pain, and then I could proceed to doing full blood count EUCs, as the patient is in shock and this could affect renal function as well. I'd like to also do a CMP, as pancreatitis can cause fat necrosis, enzymatic fat necrosis, and that can cause saponification and precipitation of calcium salts and cause hypocalcemia. I may also like to get full blood count an ABG, looking for any evidence of any acidosis. Could be lactic acidosis and secondary to potentially overlying infection. And I'd like to also get a lipase and amylase, and value greater than 3 times the upper limit of normal is indicative of pancreatitis. Then for imaging in pancreatitis, I might like to first do bedside imaging, such as a bedside ultrasound to rule out cholecystitis, look for any evidence of free fluid in the abdomen, and then I could proceed to CT of the abdomen to look for evidence of pancreatitis, and that would be my ideal mode of imaging. Is it contrast or non-contrast? Contrast. Only seen in the pancreatics. So it's contrast CT. The only time we're not doing contrast so far is if we have a kidney stone. We just do a CT on contrast. Okay. Explain the loose stools and weight loss. The loose stools occur due to 2 major reasons. There is a decrease in the exocrine function of the pancreas, and due to the inflammation occurring at the pancreas, we have a decreased delivery of proteases, lipases, and other enzymes into the bowel lumen. As a result, we don't get digestion of carbohydrates and proteins into amino acids and simple sugars for translocation across the lumen. As a result, they build up and we see steatorrhea. Additionally, the carbohydrates can act and impose an osmotic gradient, which delivers water into the lumen, and that can cause a diarrhea, and thus why we see steatorrhea and diarrhea in pancreatitis. The weight loss is due to malabsorption, secondary to inadequate absorption of nutrients, secondary to the whole exocrine pancreatic failure that we observe. Yeah, there's decreased function of exocrine tissue and there's fibrosis. What is pancreatitis and the pathology behind it? Pancreatitis is inflammation of the pancreas, and this is primarily due to inappropriate activation of your pancreatic proenzymes and your zymogens, and this could be due to multiple causative agents. It could be due to idiopathic causes, gallstones, ethanol, trauma, steroids, mumps, autoimmune conditions, scorpion stings, variations in triglyceride levels where hypertriglyceridemia when it's severe can cause it, hypercalcemia, and even procedures such as ERCP and medications such as azathioprine and Bactrim. And as a result, we get inappropriate activation of these pancreatic enzymes, and that results in destruction and inflammation of the pancreatic tissue. So we can get activation of elastases, which will destroy pancreatic elastic tissue, in addition to blood vessel elastic tissue such as collagen, and that can result in hemorrhage. We may also observe lipases being activated, and that results in pancreatic fat necrosis and the release of free fatty acids. And those free fatty acids can combine with calcium salts and cause calcification. We may also see increased inflammation resulting in edema surrounding the pancreas and peripancreatic edema, and we can also observe the release of prostaglandins, bradykinin, and other inflammatory mediators to other regional sites such as bowel lumen and to the pleura, which can result in a pleural effusion, potentially sequestration of fluid in the bowel lumen, and this can also be secondary to a paralytic ileus, resulting in third spacing and a hypovolemic shock. Describe the structure seen here. This is an atrophic pancreas, there's calcification, and this is indicative of chronic pancreatitis. And it has shaggy margins. Cells activate. Why is it calcification? It's because it's cells activated. What do we see here? Here would be your kidney, your aorta, probably your celiac trunk. That would probably be your duodenum. That's probably your IVC. Here we can see a vessel coming from the pancreas, probably a splenic vein, portal vein, and also we'll have a superior mesenteric vein joining it. Pancreatic with peripancreatic infiltration. That's your stomach right there. Next, how would you manage the patient's condition? We manage the patient's condition with medical management primarily, and this is through aggressive fluid hydration, and this could be in the form of fluid boluses up to 500 ml per hour, and constantly assessing the patient's hydration, fluid output, as the shock can affect his renal function. And we'd also give analgesia, and this could be in the form of endone, morphine, fentanyl. Endone and morphine could consider up to usually 1 to 2 milligrams, potentially IV, or we could consider fentanyl, 30 mics, and then titrate. But I would reference these dosages with ETG. And over the next 2 hours, the patient became hypertensive with pale colored extremities. Serum biochemistry is shown. Okay, we can observe there is hyponatremia, hypochloremia, azotemia, hypoglycemia, and hypocalcemia with elevated amylase. This is consistent with a picture of pancreatitis. The amylase is secondary to increased pancreatic enzymes being released into circulation. We can observe low sodium and chloride, and this could be secondary to the hypovolemia and third spacing. So first of all, we're getting hemorrhage of the pancreas due to activation of elastases that damage blood vessels of the pancreas. We also get third spacing, where the inflammatory process and release of cytokines such as prostaglandins can result in pleural effusions and sequestration of fluid in the bowel lumen. and thus we may see these electrolyte derangements. The hypocalcemia is likely due to enzymatic fat necrosis and calcium binding to the free fatty acids. The urea and creatinine could be secondary to the shock picture that we observe, and the fact that we have hypoglycemia indicates that the patient's endocrine pancreatic function is also being compromised with this pancreas. In normal pancreatic function, there is duodenal enteropeptidases, which will activate trypsinogen to trypsin, and they'll activate all the other enzymes. Do I understand third spacing? Yes, there is inflammation of the pancreas and release of these cytokines, which can increase permeability in other regional structures, including your pleura, causing pleural effusions, including the bowel, and there can also be a paralytic ileus that can also contribute to third spacing. And then there is also hemorrhaging in the pancreas itself. Alright, I think I'm done for today's study sesh. But how long did I go for? That didn't seem like too long at all. I thought I studied longer than that. Longer than one. Oh, yeah, I did study for 4.5 hours. And I am done.